Hi, my name is Dre, and I'm here to tell you a story and ask some questions that hopefully we can answer together. This project's title was based on the Dutch psychiatrist, Dr. Bessel van der Kolk's book on how children and adults adapt to trauma, without which this study would never have existed. So I have him to thank. And with that, let's begin. As of 2023, there are around 75 million children under the age of 18 in the United States. In general, around 3% of these children will get a UTI every year, and that's around 2 million kids. Of those children, up to 30% of them will get another UTI within that year. And this group of children, along with others based on a combination of factors, make up roughly 1 million kids per year who might need a diagnostic procedure called a VCUG. Now, the VCUG is the current gold standard test for children who experience these types of UTIs. And the goal is to see whether urine is traveling from the bladder back up to the kidneys rather than outside of the body. And this is what we call reflux, which can be a dangerous condition and damage the kidneys if left untreated. So nobody disagrees that a VCUG is important, but there's a serious gap in how medical institutions describe this procedure: minimally invasive, quick, and with no risks outside of X-ray radiation. And because of this, there's no requirement for signed informed consent like we might have for a knee surgery, for example. But what many children have experienced doesn't quite fit this description. And often by the time this happens, it's too late for both the child and the parent who agreed to the VCUG on their behalf. And so on my right is a drawing that an 11-year-old patient gave to me last year, describing the VCUG that she got when she was 5. And from the looks of this drawing, she clearly went through something uniquely difficult. But the thing is, she's not the only one. Every VCUG involves numerous difficult steps: the removal of clothing, genital touch, penetration, and the requirement for the child to urinate on themselves while multiple people watch and take photos. So with enough context, we as adults might be able to understand why this might need to happen, but we can't assume the same for children, especially toilet-trained children who, until that moment, have likely been taught that public urination, nudity, and genital touch is not okay. And it might not just be enough to say, well, this time it's fine because it's your doctor and it's for your health. And in many cases, providers agree. In 2004, VCUG patients were recruited as proxies for child sexual abuse victims after a physician panel determined that children who underwent VCUG experienced enough commonalities to sexual abuse that these patients could offer valuable insight on memory after assault. So the question is, do we have a dangerous mismatch in how we interpret and communicate the nature of this procedure? And if so, in what ways? Well, in recent years, stories from patients and parents have popped up on places like Reddit seeking other voices. But until now, there's been no official documentation on the potential long-term impacts of VCUG. So the goal of this study was to address that gap. I called my study Insights for Better Care, and I sought to evaluate whether VCUG plays a material role in patients' lives as adults. So when recruiting, I was purposely vague about the purpose of this study to minimize any bias and limit preconceived notions about childhood procedures that they might have gone through. And so over 9 months, I successfully collected data from 344 adults, about half of whom remember undergoing VCUG as a child. This was our VCUG group, and the rest were controls. We used online and social media channels to recruit these respondents, and all in, this project from start to finish took around 3 years. Something surprising is that in the United States, we don't have any official guidelines for how or even how often we should be performing VCUG in children older than 2. Yet 96% of the patients in this study had the VCUG in question after the age of 3, with 56% occurring between the ages of 3 and 8. So with that in mind, here's what we found. A significant association means that even though we can't say that one causes the other, there's a statistically reliable connection between two things. So we found significant associations between VCUG exposure and adverse health outcomes lasting through adulthood, including poorer perceptions of physical and mental health, higher diagnoses of long-term illness, refusing important medical care, reduced quality of life on multiple scales, and higher rates of regularly engaging in risky behaviors. But what does this really mean when we cut into each category? Well, first, we asked respondents how they would rate their own perception of their health, physical and mental, on a scale of 0 to 100. And we found that the VCUG group reported significantly lower average scores compared to our controls. We then asked respondents whether they had been diagnosed by a doctor for various illnesses as adults. And what you see here is the proportion of respondents who reported a diagnosis in the following categories. And the illnesses I show here are the ones that return significant associations between VCUG exposure and later diagnosis. But my research paper speaks more to other illnesses that we asked about that might not have been significant, but we lack the data. So they could still shed light on other long-term impacts of VCUGs. We also investigated respondents' attitudes towards certain types of important medical care, focusing on whether female respondents would get pap smears or see the gynecologist, and for both women and men, seeing the urologist and the physician. And overall, we found that the VCUG group was significantly more likely to say that they never have gone and never will go, even if they need to get certain types of care, especially when it comes to procedures for women. Some of them said, "I would rather die of cervical cancer than have a doctor touch me there again." We also probed the association between VCUG and respondents' perceived quality of life in adulthood, and we focused on certain statements that would shed light on their daily interactions, health, and relationships. So we asked them to rate their alignment with the following statements from 0 to 100, and we found that the VCUG group, for every single one of these statements, reported a significantly lower average score compared to the controls. Finally, we asked respondents about their engagement in behaviors that could compromise their health or safety. Note that we asked about regularly participating in these activities, not just once or twice. And still, we found significant associations between VCUG and a higher uptake in the following behaviors, all of which not only put personal health at risk, but could negatively influence population health and economic stability at larger scales. So after all of this work, we revisit a question from the beginning. What is a VCUG? And more so, what is a VCUG to the patient? Well, we asked them to answer in one word, and 115 of them did, here with the most frequent answers shown in the largest font. So with all of this, we're now left with a more complicated question. Is this truly the gold standard of care? And if not, what can we fix now? I can't answer that, and neither can this study. As a team of one, I funded this entirely on my own, and because of that, I didn't have the resources to collect the sample size that I would have wished for, even though today this remains the largest one ever collected. So undeniably, this study is biased. 27% of VCUG respondents found this through subreddits like medical trauma or VCUG trauma, compared to 9% of controls. But in July of 2023, a TikTok about VCUGs went viral, and this study began to receive more entries than I could count. So many that I had to shut it down early because I couldn't validate them all myself. And this confirmed the potential for research by institutions more resourced than I. And this data asks them now to step up to the plate. So what this study can answer is that VCUGs are not being correctly communicated to patients and their parents. VCUGs are not minimally invasive. X-ray radiation is not the only risk. And finally, signed informed consent should be a non-negotiable when it comes to this test. Public health is about securing the livelihood of populations, ideally while reducing costs. And at 1 million children per year who might receive a VCUG, not even counting those who will get multiple VCUGs within the year or even within the same appointment, our findings might have significant implications for public health as these children grow into adults. A hopeful outcome of this study is that we can bridge the gap from the stories that we've heard from patients, parents, and providers as well. and to enforce clinical practice guidelines and maybe even explore a better alternative down the road. But today we start here, and I'm hopeful for any discussions that might stem from this work. So thank you for your time. I have many to thank, but here I mention a particular few. And most of all, I'm grateful to every respondent, VCUG or not, who shared their stories with me. So to collaborate or stay updated with this work, please follow or reach out on our website, insightsforbettercare.org. Thank you.
Fran, that was incredible. I felt like I was watching a TED Talk. Yeah, it was. And so I guess my big question is, what next?
Yeah.
I mean, this is incredibly convincing data, like, period. Are you going to publish it? Are you going to write a policy brief? Are you going to reach out to AAP, reach out to urology organizations? What are you going to do?
It's exciting. It's so affirming to actually have the data now. We've been working on this for a long time. So I'm lucky that there are actually some women and parents who are invested in trying to get the word out. So my personal goal will be to get published by the end of this year. The journal is still kind of to be determined. I'm going to submit this abstract to PUNS, which is the Pediatric, I think, Nursing Society, in June, and hopefully they'll have me speak there. And then, I would keep an eye out because there's a growing body of women and men who on TikTok and in documentaries are now starting to talk about this. So the work won't only be mine. A couple other groups now are starting to come out of the woodworks, and I hope that we can, actually make some change by the end of next year.
I'm gonna still blown away by this. This is not anything I've ever heard of before, which is why I love these capstones, because I learned so much. I'm going to pick on the MDs in the room and ask you guys what advice you would give Dre to tackle this with physicians. What would physicians respond best to? Come on, you guys are dually trained. You should be able to.
That's the response I've been getting.
Oh, come on.
Over the last year.
I think one thing we talked about when we were going through this over the last semester was one question we had was why are kids over 2 getting VCUGs, and then what is the hospital's protocol in terms of why aren't they getting sedated for these things? Because at least what we're taught, and I'm not going into peds, but from what I remember is it's a thing where we would think about it for under 2-year-olds who are getting UTIs, and then older kids getting UTIs wouldn't be too impressive in a 3-year-old. It's not something we would necessarily run around with, at least for girls especially. It's just a big question I think we had over the course of the semester is why is this happening in that? And I think that would be a question that having an answer when you're trying to talk to physicians about this would be helpful, because I imagine they'll get stuck on that like we are.
Yeah, I would agree. I think I'm not sure how often this happens at CHOP, and also we have a very good child study team. So people would argue with that to try to say oh, it's not as traumatic as maybe the data is saying, at least here. So I would wonder, like Ben said, just having where is this happening and why is it happening that way? Because I think there are there's just no guideline over to, which you mentioned, which is so hospitals and providers are kind of left to their own devices in terms of whether or not they're doing this and how they're doing it, and whether or not they're actually sedating someone for that. So yeah, trying to figure out why it's happening in such a traumatic way, I think is really important. And then working with providers to actually enforce some kind of guideline for the people that are above 2 is definitely the way that I would go, so that people aren't left to their own ideas.
I can also offer just
Yeah.
a little bit of information. The sedation issue is so contentious for some.
I was just gonna say.
When you ask and dig into the data as to why, there's conflicting bodies of research, and every physician feels differently. What we're emerging to realize, which is again not concluded, but sedation sometimes is fine and other times is not. both in terms of preventing trauma and also in, allowing the child to actually void properly.
Right.
Physicians are worried that they won't be able to get a proper scan. That has since been debunked in certain institutions, and we've now found that getting a good result is more based on the skill of the radiologist, because this is performed often by radiologists who are not even trained in peds, not the physician. And so who's performing it matters more than how we're sedating the child. The issue is if the sedation isn't strong enough and the child still recognizes what's happening and has that mental concern, it may not prevent the trauma in the way that we're hoping. And we also don't know what exactly the rate of trauma is yet, because this is emerging.
Right.
So
I'm also thinking about the recent laws that are preventing manual exams for women without their consent when they're under anesthesia, because many of them are still remembering the trauma. So I don't think necessarily that sedation is going to help the child. But I also have hope. We had a talk yesterday, a capstone talk about changing race-based diagnoses. I think this is a good time between those two things to be pushing the medical profession, because I think there is an awareness of like, hey, we're not always doing everything right. So yeah, I don't know. I've been talking a lot. Who else wants to say something?
How do you think, excuse me, that the findings you found in your study could be translated to policies or guidelines that are going to support these patients either pre or post surgery?
yeah, I think
or
that
operation?
well, one of the things you just said is so important, right? Like this sounds like a surgery, and it's
Yeah.
not. Right now it's being treated like a 15-minute in and out situation. And so I think this data serves, and it's what I wish for the data to serve is different than what the data actually can serve. And so this is an exploratory study. And so ideally what you would do is use this to then drive future research that can actually create a causal statement, or find that it's not. So what this can really do is just kind of open eyes to this issue, say that there's a non-zero number of people who are having a very intense sequelae from this, and create kind of almost just a case statement for looking into this further and with more urgency. And if that's as much as this research does, then I've done my job. But I'm making myself ready and available to advise on anyone else who can pick this up with more resources and either build upon this study or conduct another one with a much larger, kind of more diverse sample set.
I can just also add throughout the semester, we've been talking a lot about what the next steps could be and how to approach this. And I think we always come back to trying to get this in front of as many practicing urologists as possible and just having updated, better conversations with patients before they walk into this, because I think that's the first step before, because it is an important procedure to diagnose that. And it's, like Dre said, it's the gold standard. There's not a clear, obvious choice to replace it, but making sure everyone is on board with what is about to happen and how to do it. And then maybe
Age-appropriate way of discussing it with the patient.
Right. So that it's not just this thing is happening to you and you're.
You can't just start once you arrive.
Yeah.
Right.
And so I think if there was something actionable, this data actually could support, and I touched upon this, but informed consent is just such an easy thing to instate. And last time I spoke to someone at CHOP, actually, even at CHOP, which is the leading institution and very resourced in terms of child life and trauma prevention, no informed consent required. And they weren't aware and didn't have any data until now that catheterization or the voiding on the table could have been particularly shameful to the child. So this is new.
Incredible work. Please continue.
I will.
All right. So glad that you presented it.